Afia, I'm going to start with you. Great. You were recruited in 2014 as like the first lawyer supporting health tech product development at Google. What was that all about? And tell us more about how you ended up at Waymark.
I was sitting in my office at a law firm in New York City and got this voicemail message from a Google recruiter. And the reason I responded to the message, honestly, was that I spent most of my career thinking about how technology can be used to be really impactful with respect to improving access and clinical outcomes for all people, but really focus on underserved populations. I had done that mainly in the medical device and biotech space. And so I was super intrigued by a high-tech company. And this was in 2013, before like digital health was really like,
Yeah.
I was like, they're super serious about using technology to kind of extend clinical care outside of the walls, meeting people where they are. And spent 9 years at Google, basically doing that, working with, supporting product development teams, thinking really intentionally about how technology could be impactful in terms of healthcare delivery. And in 2021, used almost 9 years of knowledge to arrive on two things that I actually wanted to test and thought would be more impactful in the community. But I personally felt that technology could help transform care delivery. And so I was very much more interested in kind of technology being used to enable care delivery. So I want to kind of test that thesis. But I also believe that it's best to kind of sit beside the physician, sit beside the nurse, really understand workflows, and kind of build technology with the input of the folks that you're trying to impact. So with those two ideas, just starting to tell my folks that's what I want to work on, and was fortunate to be introduced to the A16Z talent team. Had a conversation with Beth, who's on the talent team, and 2 weeks later, she introduced me to Rajaie. And she's like, "Oh, that's so funny. A16Z is looking and thinking about investing in a solution that sounds like it aligns very much with what you're trying to do."
As we've said on this podcast before, every healthcare company somewhere deep down could start to look like a consumer company. And so that background is just a really interesting DNA to bring to an innovative health tech company. Sanjay, in addition to being head of clinical, which is kind of an amazing purview, and excited to dig more into the New England Journal results and clinical outcomes results, that in addition to leading up clinical at Waymark, you still practice medicine. And you still see patients who bear some resemblance to the Medicaid members who we care a lot about helping. How does that practice inform what you do, and how did it inform your desire to start Waymark?
I'm in primary care, like Rajaie, doing so-called street medicine work. And so I happen to work at a community health center, which is mostly Medicaid, some Medicare patients. It gives you a healthy respect for how social and economic a lot of our interventions are in this population.
That's amazing. And it's really important that we are taking such a holistic view on what will actually be helpful for patients clinically, but also be practically deliverable to those patients. When we backed Waymark, just the extraordinary depth of experience on this team was really evident. And Rajaie, you in particular are in a special category. You're also a digital health OG, but you're also someone who we call a repeat founder, someone who's had the amazing and very rare experience of actually standing up a startup organization before and figuring out how to scale that organization. What made you say you want to do it again?
It wasn't even like a question for me. As you know, I'm a doc. My PhD was on how we pay for healthcare in low-income settings. And when we started Collective Health, we had like this broad vision of we're going to transform how we pay for healthcare across all segments, employer, Medicare, Medicaid, commercial. And that's what we built at Collective Health. And then for me, my passions had always been in Medicaid care delivery. My clinical work was focused on Medicaid. My research had been focused on healthcare in low-income settings. And I think it was really during the pandemic where I started asking, like, all of the creativity, all the capital is going into largely Medicare and employer. And Medicaid is actually the biggest, and frankly, I think the most readily addressed challenge in U.S. healthcare. And there was very little happening to take that on. And so I personally felt an obligation, like if I'm not part of the solution, I'm part of the problem, to take on and really try to use the incredible knowledge and the incredible talent that exists across technology and bring that to bear to improve Medicaid. And our approach to that was a very simple one, which, we can elaborate on, but it was this broad vision of like, actually transforming Medicaid is totally achievable. And we believe that it could be achieved on a relatively short time duration. And there was no other challenge in U.S. healthcare that I think meets those criteria, and no other challenge that I think is more meaningful.
So let's go there. Roughly 1 in 5 Americans are on Medicaid. Their healthcare is paid for by a Medicaid plan, one of the government mechanisms by which we fund healthcare in America. And that's a huge part of the population, 20, maybe going on 25% of all Americans access healthcare through Medicaid plans and through the litany of benefits that their Medicaid plan provides, and through a PCP that their Medicaid plan says is their PCP. At first glance, it also seems like a pretty daunting challenge for a startup, especially a startup with 3 FTEs, to take on.
If you kind of just step back and pause and say, yes, there's a huge and growing Medicaid population, that Medicaid programs at that time we were forecasting would be under tremendous financial pressure. The need in Medicaid is not addressed by the healthcare system, and it shouldn't be addressed by the healthcare system. It needs to be addressed in what we might think of in other countries or contexts as like the social care system, the social welfare system. And that doesn't exist in America. And instead we burden the healthcare system with those problems. And so probably like the most like acute point would be, 40% of all acute care, or 39% of all acute care in Medicaid is avoidable. That's like 3 times what it is in Medicare, 3 times what it is in commercial. And so what if you could fix that? What if you could say, let's isolate that and reduce that number? Then what you're doing has a compounding effect, because then you're actually freeing up more budget for increasing access to care. You're freeing up the resources for providers to take care of the patients that need it. And so our thesis was, we know what works in Medicaid care delivery. What works had already been published and proven by others. And so we're building on their shoulders. And what worked was moving care outside of the clinic, moving care into the community, and providing care that's not physicians or NPs, but really, often you call them community health workers, accompagnateurs, but basically the idea of navigation in the community setting to remind people that they need to take their meds, to help them problem solve, to help them get housing, to help them figure out how to get to their appointments. And that has been proven over and over. But the challenge is nobody had ever built the product to reliably implement those proven interventions at scale. And nobody had ever created the funding mechanism to make those sustainable. What we had instead is every time those interventions were proven, it was grant funded and the grant funding ran out, or it was done by what I call like a local hero, somebody who like figures out how to hire and build a team and put all the pieces together. But what we needed to do, and what our vision at Waymark was, and even though, yes, we were 3 people, we were like, yes, we're going to do this thing, was we can build an end-to-end product for Medicaid care delivery that solves the challenge of reducing unnecessary acute care use, meeting social needs outside of the clinical setting, and in turn, significantly improving Medicaid outcomes and reducing overall costs, and funding that in a way so that, it was value-based, and therefore, as we succeed, we get to do more of this.
Phenomenal. And I think we found, from an investment perspective, particularly encouraging the fact that evidence base already existed. And so the job for Waymark was to productize, to scale, and to implement with technology what local heroes had already done. And that was a really compelling investment thesis for us as well. You guys chose to incorporate as a public benefit corp, a PBC. Yes. What is that?
I'll answer what it is and why it's super important. So let's say that you are captured by the vision of Waymark, are interested in being a board director for our company. As a PBC, you know that you'll be signing up to not only be our fiduciary in terms of making sure we're building a financially sustainable model, all right, to Rajaie's point, like not that helpful to build something that's not going to be there and kind of continue to service the populations we're trying to service. But you're going to do so with a social charter in mind, right? So for Waymark is built on increasing access, increasing quality and clinical outcomes for specifically Medicaid patients, underserved populations. And so even if Rajaie wins the lottery tomorrow, Sanjay and I leave 10, 15, 20 years from now, whoever is taking on the Waymark model, and we fully intend for the care model to be servicing communities in infinite, those folks will know that not only are they responsible for making sure it's a financially sustainable business, but they have to hold true to the social charter. And so for us, it was just super important to put that out there so we're setting the expectation and people know what they're signing up for and frankly, what they're locking arms with us to actually accomplish.
You guys are run just like a startup company. You're focused on scaling, growing, hiring, all the same things, but it's it's in the back of everyone's heads. It's how we communicate as a company to our partners, to our patients, and to the community health workers, for example, our care teams. And they know that we are, formally obligated and care a lot. Sanjay, I'd love for you to just introduce us to this really amazing outcomes paper. Again, published in the New England Journal Catalyst, describing Waymark's real world, out in the community, clinical impact on Medicaid members through enabled by what you all have dubbed our rising risk signal prediction framework. Tell us about just how we got to the point of that paper. Like, who are we working with? Where?
In our first year of service, we started working with 2 health plans, one in Washington State, one in Virginia, across the two, a little more than 60,000 patients. And what the paper was doing is saying, can we actually achieve what we set out to do in that set of PowerPoint slides that were the company when we first talked to you? Can we actually pull this off? And can we pull this off with a population much larger than those smaller scale studies? So across that first year, 2023, we looked at the key outcomes that our health plans, the state Medicaid officials, and patients are looking for. Better health outcomes, meaning less emergencies, less hospitalizations, against, in our case, a control group, because we know that it's kind of cheating if you don't have a control group there to compare against. And we saw, almost a quarter reduction in emergency room visits and hospitalizations, most of those for what we call ambulatory care conditions, meaning things that good primary care should be able to prevent, a urinary tract infection, an asthma exacerbation. And it was fueled primarily by the machine learning models that help us, with a little more than 90% accuracy right now, say in advance which patients are likely to have an ER visit or a hospital visit and why, and what should our care team members do about it.
So a patient is having an asthma exacerbation. What's Waymark's role?
Key question. We're hoping to actually be there a little before the exacerbation. For example, one of the things we did earlier this year was combine the wildfire smoke data with who had asthma. And actually in both of our states, the wildfire smoke came in. It was kind of a predictive signal, and we were able to get early inhalers to those patients that help prevent emergency room visits. That's just one example of what we do, but essentially it's these teams that wrap around the primary care practice. There's existing providers who are willing to serve Medicaid patients, but they're often strapped. And essentially, we're the team that goes out in the community and surrounds them with resources they usually don't have, they and their patients. Community health workers, as Rajaie mentioned, also behavioral health therapists, since there's so much both mental health and substance use need in the Medicaid population. Pharmacists, for all the things that go wrong with prescriptions and figuring out how to take the meds, how to get the meds, etc. For example, and we see a lot of folks who are, say, on an injectable medication for the first time or taking a high-risk medication. Medicaid, unlike commercial and Medicare, has a very high rate of adverse drug events, so-called, leading to an emergency room visit. And so we can really prevent a lot of those through good education. And then care coordinators. There are people who coordinate with those primary care practices so that we're in sync and communication with their doctors and really can be a seamless team, even though we're outside the clinic and they're in the brick and mortar clinic.
Okay, so we were serving 60,000 patients across these 2 states, 2 Medicaid plans working hand in hand with us. The the machine learning model helped us figure out which of those 60,000 patients really need our early attention and intervention, because there's no way anybody could reach out to all 60,000 patients every day. So the machine learning model helps focus us. And then what did we achieve?
In addition to reducing emergency room visits by about a quarter versus that control group, we achieved a lot of improvement in access and quality outcomes. So nationally, they're measured by this Health Effectiveness Data Info System, or HEDIS, which a lot of plans, providers, and others are measuring their care quality against. Do people have access to care? Are they getting the right prescriptions for their medications and so on? Are they getting cancer screenings, right vaccinations? And so we improved those 11 percentiles, which, for me as a primary care provider, like on a good year, it's usually 2 to 3 percentile. And perhaps most importantly, we achieved 2/3 of patient goals. So one of the ways we start is not by just hammering the patient about what we want, but starting with a relationship where the patient sets a goal. So it might be a wig before they start chemotherapy. It might be food this week. Whatever it is, we start with their goals and we track ourselves against achieving their goals first. And then we talk about healthcare, which is usually after the immediate needs are addressed.
And probably worth clarifying that the machine learning algorithm is really focused on identifying who is going to use acute care in the coming days and weeks. And we call that algorithm Signal, and we actually published on that in January in Nature Scientific Reports. And that for us is really important, because if you look at what drives the cost reduction that we're able to drive, it's really driven by reductions in unnecessary acute care. So reducing overall acute care in the intervened cohort by 23%, reducing what are called ambulatory care sensitive hospitalizations by 48%. And so this is not like a blunt instrument of we're using less care. Actually, some categories of care went up in costs. We had more pharmacy spend because we had better adherence to medications. We had more primary care spend because we were plugging people into primary care for the first time. And so really the driver of like the cost reduction was that we were reducing that unnecessary acute care use, which is not good for anybody. It's not good for a patient to be admitted when they didn't have to be. It's like a win-win-win. Which is I think very rare to find.
Very special, because it's sort of the holy grail in our American healthcare system to figure out why our healthcare outcomes stack up so poorly relative to other developed countries, but we spend the most per capita. And so it has been a vexing challenge for the whole field to figure out how can we spend less, but oh, by the way, also do better. And that's exactly what this paper demonstrated, which I found so compelling, is that we are reducing the most expensive types of episodes in our healthcare system, reducing acute care visits, ER visits, hospitalizations by over 20, 25, 40%, while improving adherence to quality standards at the same time, like by the 11% metric that you described, Sanjay. So that was just kind of mind-boggling.
Yeah, and I think what we're doing with this research, and like we don't write like a blog post on it, we actually publish an academic paper on it. And so that very much is who we are. But part of what we're doing, I think, is defining this new category of patient that we're calling the rising risk patient. Because I think before we started doing what we do, most health plans, most providers in Medicaid were focused on basically the complex or high cost claimants. And one of the things that we did in creating the ML model, that Signal that does that risk identification, is figure out that actually if you look at those high cost claimants and you look at the algorithms that are used to identify them, there's a couple of very common ones. By the time they identify a patient, that patient's cost, and this is according to the National Medicaid database, which we pulled, is already on the downward trajectory. And so whether they get an intervention or not, there's not really a delta in their cost. But where the opportunity is on those patients that are rising risk, which actually at that month zero, the time at which we identify them, their cost profile is not meaningfully different than the cost profile of your average Medicaid patient. But our algorithm is trained not on cost or prior utilization, but on condition and social risk factors and the various other data feeds that tell us about behavior, the kind of admission, discharge, transfer feeds. We can see whether they're picking up their meds. And that's actually what informs our view of somebody's risk. And when we identify a patient, they're at average cost. And what we saw is those patients that we identify and don't engage, their costs balloon, where that category of patient that we work with, we're able to, their costs still go up over the baseline, but it's a dramatically less.
That's super interesting. So if you find yourself, if you find a patient who was just in the ICU, had a lot of cost, you could pat yourself on the back and say, hey, I found a high cost claimant, but like it was too late. And instead you got to find the patient who has hypertension, isn't managed, is a walking stroke risk way before they end up in the ICU, and hopefully actually avoid the ICU visit altogether. So if everybody wants to do that, why aren't more groups able to?
If you're in community, guided by community, you would be able to be more effective and efficient in terms of reaching to the right people and frankly, like engaging in behavior change to see the outcomes that we did see. So in addition to all the things that Rajaie and Sanjay have discussed in terms of the value of this paper from our 2023 first year results, I think it's a validation of this community-based care model in a way that's incredibly impactful. And the way we're doing the work is that community-based care is not reimbursed in a fee-for-service system. And so we are doing risk-based contracting to make it work. But we're hopeful that putting out peer-reviewed publications like this just kind of validate how impactful community-based models paired with, I think equally importantly, technology that allows you to identify the right folks with the right intervention can be really transformative in terms of bending the cost curve and, I think more importantly, improving clinical outcomes for underserved populations.
Yeah, it's a really interesting dual identity the company has as both bleeding edge and machine learning. Tell us a little more about the technology behind the platform and the data science that goes into, figuring out rising risk.
Yeah, there's a few different fun parts. Our data science lead, Sadek, he refers to it as kind of participatory data science because the community health workers and care team are like, I kind of faced this problem today. Can I lob this over? And you guys mull it over a little bit. And it's a very different way of doing data science than what we usually do, which is what data is available, which data is clean. Let's work on that because that'll be the way that we can kind of get something going. So a lot of our ML AI work is really to help reduce the burdens on our staff so that they can focus on the patient and not focus on filling out the housing application or being on directory assistance forever in order to find out which shelter has an opening or filling out prior auth forms or DME forms. And so a lot of it is sort of the unsexy administrative work, but that's also what burns people out of this kind of work. So they get to focus on the patient and then let the forms write themselves, let the documentation do themselves. And for consistency and quality, it also populates the right guidelines in our internal CRM so that the staff who are new can get some of the experience from the staff who are very experienced and say, actually, I really need to do the substance use counseling today before I worry about the glucometer. That's the right order of operations for this particular patient. So we continue to iterate on it. Of course, we're sitting in the hub of lots of generative AI learning. We certainly learn from our broader community in tech, but I feel like one of our fun and strategic ways of operating in that tech is to have an internal group that's facing patients every day and really testing it out and saying, this is not really the problem I want to solve with this. Can we redefine the problem and then you guys can play with the solutions and figure it out?
I would add, I think if we're going to take on this massive challenge of making Medicaid care delivery better everywhere, the solution that we build needs to be able to allow us to be radically more efficient and effective at implementing these solutions. And so let's start with just even the ML predictive model Signal. If you didn't have Signal, you'd have about 30% accuracy in identifying future acute care use. That means 7 out of the 10 patients that you reach out to, you're not going to actually benefit in a way that changes the outcome.
Right.
With Signal, you have 90% accuracy. So that means 1 out of 10 of the patients that you reach out to, you're not going to benefit. And so that is a radical improvement in the efficiency of how our people spend their time. I think the other part that gets to reproducibility is, everything that we're building that Sanjay was just talking about in terms of task automation. The best CHWs have years of experience. They they've been doing this. They understand the process. They know the social safety net and the community-based organizations they can tap into. What we need to do, and what we've done through our platform, is make it much, much easier to be a massively effective community health worker. That means that they're not spending their time doing routine documentation or putting in referrals or calling to schedule appointments. We can automate using the best of AI those tasks and let them focus on being present with the patient. And so I think what we're doing is really enabling reproducibility and efficiency of this model in a way that's orders of magnitude better than it had been before.
For those of our listeners who might be familiar with kind of the biopharma world or the clinical trial world, it's really eerie how similar what you're describing is to the evidence base for a drug. And Waymark's interventions look like a drug that is working for Medicaid members. And in the drug space, we think about the number needed to treat. We think about how big an effect size might be for patients who, have challenges and are facing, disease. And we also think about precision approaches. And one of the biggest upheavals in the biopharma space has been our ability to actually, in a precise way, use biomarkers to pick which patients are supposed to be treated with a drug. And it just strikes me, like, just hearing you guys, that you're doing it in health tech where no one does it that way. First of all, no one runs the trial the way you guys ran a controlled trial. But more importantly, the precision targeting, figuring out which patients are most likely to benefit from your intervention, and then measuring what that intervention did. I really applaud you on taking kind of a level of rigor that we don't see as often in health tech. It's amazing.
I think the biggest difference is that if this were a drug, it'd be medical malpractice not to give it.
So how do you scale it then? A drug, we think about we're going to scale up manufacturing. Like, how does this work for us?
That is sort of our challenge for this year. It's great to have 2 health plans in 2 states, but we're ramping up pretty quickly to others. One is making sure the tech is consistent, the quality is consistent, making a new workforce of community health workers. I think the other aspect of this is finding really great partners. There's a lot of primary care partners and health systems and health plans who have dipped their toes into this and gotten burned before because they were trying to invent everything from scratch.
What needs to change outside us? You kind of hinted at this, that, we need to find partners who are willing to tango on this. And they should feel like they have to tango with us on it based on the evidence. But, nonetheless, some things might need to change outside our org. That's kind of the way it is with startups. What are we looking for to change around us? What are the Medicaid plan kind of constraints that exist? What are the care delivery constraints that exist? What do we need hospitals to do to make this work?
I don't think we need a miracle to make this work. So we don't need a new piece of legislation. We don't need kind of a fundamental realignment of incentives. I mean, our approach in building the model the way we did was we're meeting our very imperfect healthcare system where it is. And I think some of the adaptations that we've made to enable scaling are actually coming up with new contract models so that we can really coexist with providers that are in value, and Medicaid health plans own care management programs. And we've written a few pieces now on basically this idea of fake value-based care. We called it value veneers. And I think that's actually been one of the biggest challenges and impediments to adopting non-fee-for-service models in Medicaid is, the default mentality is, if there is a value-based flag planted somewhere, then that territory is claimed. And even if that value-based flag doesn't come with new care delivery resources or any new clinical staff or programs, it kind of puts it off limits. And what we're finding is we can coexist with those through some new contract evolutions that we're doing. So many providers, big health system have in place a Medicaid ACO where they'll have a shared savings agreement with a plan, but it's kind of like rolling the dice every year, and it's upside only. So If trend comes in lower, they get, a small bonus payment. And if it doesn't, then they don't. But it doesn't change any of their daily practices or how they manage patient care.
Mm-hmm. And the ACO doesn't have a rising risk model and doesn't have community health workers or pharmacists or additional resources to actually drive those savings. And so you're saying some of those situations look like veneers that are like mirages in the desert. Like maybe there's water there, but like
exactly,
really
it's not changing care delivery.
I think there's ways and we could change the system to make it easier to do the work, to scale more quickly, to reach more people more quickly. One thing is more value for community-based care. Like there's movements to have CHW services reimbursed. That's kind of in a fee-for-service model, but it's moving in the direction of kind of recognizing that there's all these health-related social needs that Rajaie mentioned earlier that are totally impactful to cost. And I think there's movement toward pushing care outside of the clinic walls, right? And technology is a way to do that, et cetera. And so I think telehealth is a way to do that. So I think there's ways in which you can make what we're doing easier. But what I love about our paper is what Rajaie just said, right? Like, given the current system, we've shown that we'll be able to kind of operate in it and decrease costs to the system and improving clinical outcomes for our folks as well.
You guys are working with food banks and post-incarceration housing and organizations, all these community organizations too, right? That often we've assumed are taking that approach and are kind of trying to look at families as entities and communities holistically, but clearly, they're resource constrained too. But do you want to say a word about how we as a startup figure out how to interface with all the community organizations across the country?
Yeah, healthcare works at the speed of trust. So a lot of it happens through local relationships and just getting to know folks and showing up. A lot of our primary care providers have been burned before by more faxes and more inbox messages from various parties they don't even know, but it's nice when our community health worker actually shows up in person to the appointment with the patient and just changes the whole dynamic and the ability to navigate and communicate and understand what's going on.
Thank you all. Thank all of you, Rajaie, Afia, Sanjay, and really the extended Waymark team for all the work that went into building, launching and scaling one of the most innovative models for Medicaid healthcare. So thank you all.